It's my pleasure to introduce one of our, let's go. Do you understand? It's my pleasure to introduce one of our chief residents, Dr. Tatiana Cardenas. Dr. Cardenas grew up in Miami, did her undergraduate work at the University of Miami, went to Meharry Medical School where she also got a master's degree in microbiology and immunology, and then came and joined us here, completing her residency in June, hopefully, and then on to a trauma fellowship here at our own institution. Please help me welcome Dr. Cardenas.
Good morning. So as Dr. Cernik said, thank you, I'll be talking about surgery in the pregnant patient. First and foremost, I have no financial relationships to disclose, and given the breadth of this topic, I think that it's important to establish a couple different objectives and purposes of why we're here today. First, to understand the physiologic changes that happen in pregnancy and then their clinical significance. In addition, to understand how different imaging modalities will affect fetal development, and then how common surgical conditions will present in pregnancy, and then what their treatment is and the complications associated with the treatment. So first, we'll go by systems for physiologic changes. First and foremost, the hematologic system and fluid and hemostasis. So initially, I think the biggest theme, overarching theme of this system in pregnancy is volume expansion. There's about a 3 to 4 liter increase in total body water. 2 to 3 liters are placental fetal circulation, and then more than that, 1,500 is an increase in maternal blood volume, with 1,200 being plasma and 300 cc's approximately being red blood cells. What this means is there's an inherent physiologic anemia that's present secondary to an increased plasma volume relative to the red blood cell mass. In addition, this also means that there's some baseline interstitial edema in the pregnant patient secondary to decrease in the plasma protein relative to increase in volume. In addition, you've got increased cortisol production, which yields a baseline leukocytosis. And finally, there's an increase in clotting factors as well as increase in venous stasis, and that's usually secondary to IVC compression from the gravid uterus, and that yields a hypercoagulable state. And so the effects of these changes, or what they mean clinically, is that, in pregnant patients, they can tolerate about 2 liters of blood loss without a change in heart rate or blood pressure. So that's particularly important in the trauma patient. In addition, there's a baseline, like I said, interstitial edema, but it's even more pronounced postoperatively after any kind of surgical procedure secondary to increased capillary permeability to protein and salt. So volume needs to be used judiciously. And leukocytosis in the pregnant patient is going to be a little less sensitive when evaluating for any infectious processes. And you need to look a little further for, fractionation and neutrophils. And then in addition, of course, with venous stasis, there's a 5-fold increase in venous thromboembolic events. So DVT prophylaxis is especially important. Within the cardiovascular system, there's also effects that are caused by this fluid expansion. And so not only do we have fluid expansion, but we've also got increased metabolic fetal demand. And this inherently increases stroke volume and heart rate, where stroke volume can increase by up to 50%. And because of this, you've got now an increased cardiac work and cardiac output up to 140% of what's their normal baseline. This in turn causes enlargement of all 4 chambers. In addition, there's also effects that are on that the CVP and pulmonary pressures and systemic pressures will see. So usually with increased fluid expansion of 3 to 4 liters in a non-pregnant patient, so you subtract the gestational physiologic changes, you would expect to see an increase in CVP, pulmonary and systemic pressures. However, progesterone makes all the difference in the world, and that actually decreases the CVP, pulmonary and systemic pressures, so that the patient is normotensive and doesn't have pulmonary hypertension. The reason why is because progesterone is a venodilator, and it also it's an arterial dilator. And so what this means, usually with increased cardiac output, there's a predisposition of the pregnant patient to develop AFib and mitral regurg, and that's secondary to having the enlargement of all four chambers. In addition, the pregnant patient is extremely sensitive to preload changes, and that's basically because of the need to maintain this cardiac output and stroke volume from the volume expansion. Combine that with the placenta being unable to auto-regulate blood flow, and the blood flow being dependent on maternal blood pressure, that makes for a pretty catastrophic set of circumstances if the patient has all of a sudden, an acute hypotensive episode, which would decrease the fetal circulation. In addition, compression of the IVC, for example, by the gravid uterus can also result in a 30% decrease in the cardiac output. And that would also, of course, decrease the fetal circulation. So usually, intraoperatively and generally, you put the pregnant patient in the left lateral decubitus position, especially in the second and third trimesters, to avoid this phenomenon. And lastly, persistent hypertension in a pregnant patient is not normal. They've got progesterone. Again, it's a veno and vasodilator, so it should be worked up. With regards to the respiratory system, physiologic changes, again, related to the increased metabolic demand. So there's increased O2 demand and carbon dioxide exchange. And so thereby, that results in increased minute ventilation, mostly the tidal volume increases by about 40 to 50%. There's a baseline respiratory alkalosis that is experienced with the PaCO2 of the pregnant patient baseline, and normally would be 30 to 33. As a compensatory measure, there will be a metabolic acidosis, so you'd have a bicarb of about 20 to 22 to help better normalize the arterial pH. In addition, mechanics of pregnancy also will have an effect on the respiratory system. So a gravid uterus is going to, as gestation progresses, a gravid uterus is going to impinge on the diaphragm, which leads to a 5% decrease in total lung capacity, as well as a subsequent decrease about up to 30% of functional residual capacity. This makes the pregnant patient pretty susceptible to hypoxia from atelectasis. And why this is important, so when you talk about hypercapnia, in terms of fetal clearance of CO2, the fetal placental circulation will decrease clearance of CO2 at a maternal PaCO2 of 40. And so that's actually, in a non-pregnant patient, as everyone knows, that's right smack in the middle of what normal would be. And in addition, the pregnant patient is pretty intolerant of any apneic episodes or a decrease in tidal volume or slowed respiratory rates. What this means for us as surgeons is, especially during laparoscopy, end-tidal CO2 monitoring and arterial, or in the form of arterial CO2 monitoring, are imperative, because carbon dioxide diffuses between the peritoneum bloodstream, maternal bloodstream, and the fetus. So that needs to be accounted for, secondary to the sensitivity of fetal clearance of CO2. With regards to the gastrointestinal system, there are 3 different points to make. First, progesterone is going to also, just like it causes veno and vasoarterial dilation, it's by definition, it's a smooth muscle relaxer. And renders the GI tract relatively hypokinetic. The effects of that we'll go over in a second. In addition, the gravid uterus causes visceral displacement as gestation progresses, and therefore causes atypical signs and symptoms of the usual intra-abdominal infectious processes that we see when patients come in, with right lower quadrant pain or right upper quadrant pain. It's not going to necessarily be as straightforward. And then, of course, the last thing, stretched peritoneum. Because of this stretching, there's decreased sensitivity to peritoneal irritation. So an abdominal exam, although is imperative to do, it may not be as reliable. And so this overall hypokinetic state of the GI tract is seen and manifests itself as mostly in the foregut when we see decreased lower esophageal tone resulting in about 80% incidence of GERD associated with gestation. There's also an inherent risk of aspiration secondary to the same decreased lower esophageal tone, and we see this as early as 12 to 16 weeks when the uterus comes out of the pelvic rim. We can decrease these risks by elevating the head of the bed of the patient, having sleep on pillows, and then also starting PPIs and H2 blockers. And finally, decreased gallbladder motility is seen secondary to progesterone as well. And there's actually a 3-fold increase in the prevalence of cholelithiasis during pregnancy, but the incidence of symptomatic cholelithiasis and acute cholecystitis does not change as compared to the non-pregnant patients. With regards to radiographic imaging in pregnancy, I think this is an important topic for us to touch on. So just some basic definitions. Centigrade, that's the dose of radiation that's absorbed per mass of tissue. It's not indicative of total ionizing radiation exposure, but it does indicate the radiation absorbed. And 1 centigrade equals 1 rad. And so the rate of childhood cancer, just to put it in perspective, and leukemia is about 0.2 to 0.3% baseline. Radiation exposure to a fetus can increase this incidence to about 0.06% per rad of exposure. And with regards to susceptibility of the fetus, the time that the fetus is most susceptible to the teratogenic effects of the ionizing radiation is during organogenesis, and that's within the first 15 weeks of pregnancy. The most common negative outcome that's seen secondary to this is mental retardation. It can also have microcephaly, ocular malformation, and cataracts. These effects are less common after 15 weeks, but then again, pediatric malignancy risk can increase based on my second point. So the max recommended dose of radiation to the fetus throughout pregnancy is going to be about 5 to 10 rads. Any one study can't be more than 5 rads. And so here's just a table summarizing exposure to the fetus in common radiologic studies in terms of rads. And so it goes anywhere from a plain KUB going from 0.1 to 0.3 rads up to an ERCP, and without pelvic shielding can go up to 12.5. The CT of the pelvis can be as little as 2. When adding the abdomen, that's when it goes up to 5. And so when comparing ultrasound, CT, and MRI, those are the mainstays of radiographic imaging modalities that would be used for most basic abdominal, intra-abdominal pathology. And so with ultrasound, of course, there's no risk to the fetus, but it is operator dependent, and diagnostic sensitivity is dependent on that operator. For appendicitis in pregnancy, the sensitivity is anywhere between 66% and 100%. And mostly that's having to do not only with the fact that it's operator dependent, but also with the fact that in the first and second trimesters, the rate of non-visualization of the appendix is not as high as, let's say, in the third trimester. So the rate of non-visualization after the second trimester can reach about 90%, which is why we see a decrease in sensitivity of the ultrasound. And then in terms of evaluation for gallbladder pathology, it retains its utility because there really isn't a change of sensitivity and specificity with regards to the pregnant patient and gravid uterus. For CT, appendicitis is the most common reason for obtaining a CT in the pregnant patient. Sensitivity and specificity are high, 97 and 100%. Pulmonary embolus also is another reason why a CT would be obtained. And actually, when CT and VQ scan were compared, CT was found to have a lower total radiation with really no change in the diagnostic yield. So a CT is going to be the one that we want to go with when we actually thought that VQ would intuitively VQ scan may be the one that would be chosen. And then based on with regards to trauma, ATLS, ACS, and ACOG all state that CT is the best choice for abdomen pelvis imaging regardless of pregnancy. And then moving on from that, in terms of MRI, there aren't any studies suggesting teratogenic risk to the fetus with regards to the IV gadolinium. However, in animal studies, it does show that there is teratogenic effects. These are frequently MRI without gadolinium is frequently used for evaluation of appendicitis, and that sensitivity is anywhere from 80 to 98% with a specificity that's pretty high, 94 to 100%. But again, similar problems, not to the extent of the ultrasound, but with advanced gestational age, it becomes just more and more difficult to visualize the appendix. And then in terms of initial evaluation in a traumatic patient, there isn't really a role for MRI in a patient for the initial management. Subsequently, the patient can undergo an MRI if, once the critical and life-threatening injuries are addressed, but initially takes too long. Usually it's across the hospital, isolated area, so not ideal. The overarching theme, though, and this will change with certain surgical conditions that we're trying to diagnose, but overall, expeditious and accurate diagnosis should take precedence over concerns for ionizing radiation when it comes to more urgent or emergent general surgical or surgical conditions. So evaluation of the acute surgical abdomen in the pregnant patient. There are just a few changes that we see in terms of displaced viscera, which that's mostly what's going to affect our physical exam when we go see a pregnant patient with, acute onset of abdominal pain. Mostly, so the stomach will be moved further up and over to the left upper quadrant. In addition, the small bowel and transverse colon will also be relocated to a more upward or cranial position. And then the ascending and descending colon are going to be found more laterally, and also they'll be pushed up by the gravid uterus. This is going to manifest itself, or the effects of these changes are going to manifest itself with regards to common general surgical conditions in the pregnant patient. So first, we'll go over appendicitis in the pregnant patient. So this is the first, number one most common non-obstetric problem requiring surgical intervention in pregnant patients. The incidence is about 1 in 14 to 1,500 pregnancies, and it's seen more commonly in the first and second trimesters. The big take-home theme of appendicitis is the risk to the fetus. So fetal demise is up to 5% in acute appendicitis, and anywhere from 20 to up to 36% with perforated appendicitis. And the rate of perforation in pregnancy is actually significantly higher than what it is in the general population, and that's thought to be secondary possibly to and most likely to delayed diagnosis. So it's up to 43% in the pregnant patient, where in the general population, perforated appendicitis is about 19%. Appendicitis and diagnosing appendicitis in the pregnant patient can be a diagnostic dilemma for sure, because typical symptoms that present with appendicitis can also be present in a normal pregnancy. So nausea, vomiting, anorexia, abdominal pain, leukocytosis that we talked about previously. Anorexia, to complicate things a little bit more, is actually more common in the non-pregnant patient than in the pregnant patient with appendicitis. And peritoneal signs aren't going to be as prevalent in the third trimester, given how lateral the the ascending colon gets pushed back. And so that doesn't really help us much at all. The only real consistent symptom is about right-sided abdominal pain, but of course the location is variable depending on how gravid the uterus is. Ultrasound is useful, like I said previously, in the first and second trimesters, with the third having a decreased sensitivity and specificity secondary to non-visualization of the appendix. If ultrasound cannot visualize it, then okay to use MRI without IV gadolinium and can be performed at any stage in pregnancy. And then in terms of CT abdomen pelvis, radiation dose, as I also mentioned in that previous table, can reach up to 5 rads with the abdomen pelvis CT. And so it's considered safe after the first trimester, but may have teratogenic effects and risk of childhood malignancy. So the risks and benefits need to be weighed with, physical exam and patient stability. Bottom line, diagnosis can be a huge challenge, specifically with appendicitis, and that's the overarching theme in diagnosing appendicitis, and becomes problematic for the surgeon. And so what do we look for? Acute onset of right-sided pain, not chronic pain that's been around for a couple months, but we're looking for acute onset of right-sided pain. We can look for a leukocytosis with a predominance of neutrophils, because as we know, leukocytosis is going to be a baseline norm for many pregnant patients. So you look for neutrophils, and then you have to have a high index of suspicion when you're talking to the patient and obtaining a history and doing their physical. And so with treating appendicitis, non-operative management, open appendectomy, and laparoscopic appendectomy are 3 treatment modalities that have been studied. Non-operative management is not applicable to the pregnant patient, given that this group has previously been known to have the highest risk of fetal demise, secondary to antibiotic failure, with subsequent progression to perforated appendicitis. And as we know, we went over the stats a couple slides ago. The fetal demise rate is anywhere, can go up to 36% in perforated appendicitis. So not operating is way too risky. Open appendectomy, the advantages is that there's no pneumoperitoneum, so you don't have to deal with the effects of the carbon dioxide and end-tidal CO2 monitoring, with the risk of increased maternal PaCO2. And there's no injuries related to trocar placement, but there is less visualization. And if uncertain about a diagnosis, so we know a patient has some acute symptomatology, can't really nail down a diagnosis preoperatively with an ultrasound or MRI or CT scan if that was done, it's difficult to intervene on other pathologies. So if the patient, has a normal looking appendix, when you go in for an open appendectomy, it's much more difficult to, then look at the gallbladder and perform a cholecystectomy, let's say, from an open incision. The laparoscopic appendectomy has, on the contrary, has improved visualization and improved access to the relocated appendix. And it also allows for ability to intervene on other pathologies a little bit easier. There's also a tendency for decrease the length of stay and decrease pain, and the patient will, go back to normal life and normal daily activities sooner. So historically, we initially thought that laparoscopic appendectomy was thought to have a higher fetal loss rate, and higher complication rate as compared to open appendectomy. But more recently, data has come out that laparoscopic versus open appendectomy both have about the same maternal and fetal risks. We also know that now, given that there's similar maternal fetal risks, and given that it's shown to be safe, we can actually do this during pregnancy, and it's therapeutic and diagnostic in the event that the appendix is normal or that we're unsure. But we know that there's some sort of abdominal process going on. We can also easily intervene on other pathologies. If appendicitis is not unequivocally ruled out as the diagnosis, an appendectomy should be performed, or a diagnostic laparoscopy to perform an appendectomy or evaluate the abdomen needs to be performed, because the risk of the patient progressing to perforated appendicitis and the risk that poses to the fetus is significantly high, and so it needs to be operated on. There is a negative appendectomy rate in the literature up to about 36%, which is pretty high, but I think I would much rather settle and accept a higher negative appendectomy rate, given the benefits that it would, produce for the fetus and the decrease in risk of fetal loss. And so overarching recommendations, expeditious and accurate diagnosis needs to be priority over ionizing radiation of the fetus. And then also initial abdominal access. This is in terms of port placement. That's another relatively controversial topic. SAGES is saying that it can be done either open Hassan technique or the varus needle or an optical trocar, and that's if the location is adjusted according to the fundal height and previous incisions. And then laparoscopy can be safely performed during any stage in pregnancy, and that goes for laparoscopic appendectomy as well with patients with appendicitis. Biliary disease is another common surgical problem that we see in the pregnant patient. It's the second most common surgical problem that is non-obstetric that requires intervention. And again, as I mentioned before, although the incidence of cholelithiasis is increased in pregnancy, the incidence of symptomatic disease or acute cholecystitis is the same as the non-pregnant patient, so that doesn't change. Diagnosis with this particular disease process is not the problematic part, given that the ultrasound retains its utility through whichever stages in pregnancy. It doesn't really affect the sensitivity and specificity, but rather the decision-making in terms of intervening or not, medical management versus surgical management, delaying operation or not, is the discussion. And so historically, we've seen with cholelithiasis in pregnancy, obviously asymptomatic cholelithiasis they don't require an operation. Here on the left side of the diagram, symptomatic cholelithiasis was previously treated non-operatively and delayed operation until after delivery. However, there's been a shift in management, and what's recommended is actually early operation for symptomatic cholelithiasis. And here are some reasons why. So 50% of gravid patients who present with biliary symptoms are managed non-operatively. They're going to have a recurrence. Why that's a problem is because 23% of those patients who recur are going to develop either acute cholecystitis or biliary pancreatitis. And the problem with biliary pancreatitis and having a possible 23% incidence of that with recurrence is that acute biliary pancreatitis yields about a 60% fetal loss and has also a 15% maternal mortality rate. So these are pretty high risks to take. Non-operative management of symptomatic biliary disease overall yields about a 7% risk of fetal loss, and non-operative management is also associated with increased number of hospitalizations, preterm labor, as compared to patients who just have an early cholecystectomy with biliary symptomatology. There's about a 2% fetal loss when urgent biliary operations are needed and performed. So a summary of recommendations for biliary disease, taking into consideration all of these different facts, is first and foremost, laparoscopic cholecystectomy is the treatment of choice when dealing with a pregnant patient in gallbladder disease. It's been effective and safe in pregnancy. Also, we don't defer symptomatic biliary disease. We don't defer these operations until after delivery, because the incidence of recurrence and the incidence of having even more complicated states with fetal demise increases. In addition, same in terms of the location of initial abdominal access as with appendectomy. And then intraoperative cholangiogram will expose the mother and the fetus to some radiation, but it can be used selectively in pregnant patients as well, and the lower abdomen should be shielded. Lastly, with choledocholithiasis, which specifically I didn't, give statistics on. However, studies with ERCP preoperatively and postoperatively with choledocholithiasis have been done, and ERCP is shown to be safe in the pregnant patient and can be done in conjunction with a laparoscopic cholecystectomy, but also laparoscopic common bile duct exploration can also be performed. This is another pretty big topic with regards to the pregnant patient is breast disease. This is another diagnostic dilemma in the pregnant patient. This happens because of the physiologic changes and increase in circulation of hormones within the breast that induce proliferative glandular and ductal proliferation of glandular and ductal cells. In addition, because of that proliferation, the breast becomes nodular and firm, and then it becomes pretty difficult to detect and subsequently manage new lesions, or even know that a new lesion is present. And so with the evaluation of malignant breast disease in the pregnant patient, mammography, of course, has a risk of radiation exposure, but the breast itself appears dense and coarse, it's heterogeneous and nodular. So these features are all features that decrease the sensitivity. Similar features to younger patients with dense breast tissue, and so it decreases the sensitivity of the mammography, where normally it would be about 90%, it decreases it to about 65%. Again, if the mammography is performed, it needs to be done with a shield. However, I think the better choice for first-line treatment, for first-line evaluation or study of a breast mass is the ultrasound, and this is because it's able to discern normal dense parenchyma from an actual true mass, and this can be done in a pregnant or lactating patient. The sensitivity of this is about 100%, and there's no risk to the fetus. And finally, the MRI. Routine use of the MRI in pregnancy is not really supported by literature, given the effects of IV gadolinium. It's okay to use in a lactating patient as long as breastfeeding is avoided 24 hours after the gadolinium is administered. And so, going along with the evaluation of malignant breast disease. So the optimal time for a clinical breast exam is the first prenatal visit. It's good to get a baseline exam, and that way when the breasts become dense and nodular, there's a baseline to compare it to. In addition, about 80% of the masses that develop during pregnancy are benign, but diagnostic delays with breast cancer associated with pregnancy are common. So if there's a mass that is present for more than 2 weeks, then it needs to be further evaluated. Ultrasound-guided core needle biopsy is usually the mainstay of, is the standard in terms of biopsying these masses. However, with that, there's increased risk of bleeding, infection, and milk fistula because of dilated ducts and increased vascularity of the breast in the pregnant patient. However, this is still used as a standard for biopsying these and diagnosing these breast masses. So the first breast disease process I want to talk about is phylloides tumor. So it's going to originate from intralabular stromal breast tissue, and about 10 to 40% are malignant, but the treatment is surgical excision with negative margins, and that's the gold standard. And the survival and prognosis is excellent. It's greater than 95%. More commonly, with regards to pregnant patients, we're going to see pregnancy-associated breast cancer. And that's, the definition is breast malignancy that's detected during pregnancy or within a year of childbirth. It's the second most common pregnancy-associated malignancy, and that's second to cervical cancer, and it accounts for about 3% of breast malignancies that are diagnosed. The incidence also, it's been observed that the incidence of PABC may be on a rise or may be increased, and that's given overall tendency for women to delay childbirth. In addition, in terms of presentation, more than 90% of women who are diagnosed with PABC present with a palpable breast mass. They may also have a history of infant rejection of the milk from the affected breast. Contrary to what we see, bloody nipple discharge at presentation is very rare with pregnancy-associated breast cancer. In addition, they tend to be historically have a poorer prognosis and decreased ERPR receptors positivity and increased preponderance for H2 expression. So this poor prognosis, it may also be related to a delay in diagnosis. So it may inherently be because of increased HER2 and ERPR negative status, as well as a delay in diagnosis. And so we divide treatment based on trimesters of pregnancy-associated breast cancer. So in the first trimester, usually modified radical mastectomy is offered, and that's the safest approach. It negates the need for radiation therapy, which radiation should be delayed until after delivery. Now, the reason why we would choose to do modified radical mastectomy versus, a lumpectomy with breast radiation is because if you delay the radiation up to 30 weeks, this increases the risk of local regional recurrence. So breast conservation therapy is usually not offered in the first and second trimesters. In women with advanced stage tumors, where surgery is surgery as the first line of therapy is not an option. Discussion of termination is a pretty reasonable discussion to have with the patient, given that a delay in systemic chemo, anywhere from 3 to 6 months, that would increase the risk of metastasis by about 5 to 10%. And so these are all important, really life-changing decisions that the patient and family and along with the surgeon need to sort of make, because it affects the patient outcome. In addition, delay in chemo with patients with poor prognoses also will decrease disease-free survival. And then in the first trimester, in any trimester, hormonal therapy is contraindicated. With the second trimester, any combination of surgery with either neoadjuvant or adjuvant chemotherapy is offered. Chemotherapy has been shown to be safe in the second and third trimesters, and the regimen that they've looked at is 5-FU, cyclophosphamide, and doxorubicin. And again, it's safe to start these in the second trimester. Again, no breast conservation therapy because radiation therapy needs to be delayed until after surgery. And again, the risk of delaying radiation therapy increases the chance of local regional recurrence. And then, as previously mentioned, hormonal therapy during pregnancy is contraindicated. Finally, in the third trimester, we, again, same options as the second trimester, but now breast conservation therapy can be included in that, and that's because radiation therapy, it's still going to be delayed until after delivery, but you can have radiation therapy as a choice up to 12 weeks after excision of the lesion, and it'd still be effective. And so there's some data on using sentinel lymph node biopsy with modification of the isotope dosage, but methylene blue should not be used. There isn't any difference in wound complications in terms of breast conservation therapy versus mastectomy during pregnancy. Obviously, this was just looked at subsequently in the third trimester and after childbirth, and same with hormonal therapy, that is contraindicated. And so a summary of the management of pregnancy-associated breast cancer is illustrated here. It's essentially, you know, at the first trimester, no breast conservation therapy, and defer chemo to the second and third trimesters, and modified radical mastectomy is usually with first trimester, and second trimester is the surgical management that is offered. Like I said, chemotherapy is safe in the second and third trimesters, and breast conservation therapy can be initiated with, you know, resection with radiation therapy after delivery, because it's the radiation therapy will still be effective 12 weeks out from the excision. But it's extremely important to discuss, you know, the patient's options, and the risks associated with these options to both mother and fetus, because it's pretty complicated. I think this is a grand rounds topic in and of itself. Additional surgical conditions that I did not go into detail on, that because they essentially mimic or mirror the management algorithm of non-pregnant patients, is as follows. So small bowel obstruction, you have similar management, non-operative management, initially NG tube decompression. However, there's a little more aggressive and sooner intervention in the operating room, secondary to maternal mortality being up to 20% and fetal mortality anywhere from 25 to 50%. So we'll intervene on those a little sooner than non-pregnant patients. Acute diverticulitis management mirrors the non-pregnant patient, and colorectal cancer is also another topic that sees a delay in diagnosis oftentimes. Similar management algorithm to non-pregnant patients, and so resectable disease should be resected without delay, and that's during pregnancy. The only difference is that if the delivery is nearby and forthcoming, then resection can be delayed until after delivery. So late in third trimester is really the only exception. Thyroid nodule is going to be worked up the same way as the non-pregnant patients, and if on FNA, if there's thyroid cancer or follicular cells, given the indolent course of thyroid cancer, there is an option to delay surgery until after delivery. But again, you know, this is something that needs to be discussed with the patient, given the effects of thyroidectomy on the fetus during gestation. And then finally, trauma. It's standard ATLS, initial evaluation and treatment. Any intervention that's required to save the mom's life should be performed. In addition, because of that volume expansion and the predilection for pregnant patients to tolerate up to a 2-liter blood loss without change in heart rate and blood pressure, early aggressive resuscitation should be considered even in a normotensive patient. And then pelvic exam and fetal monitoring are imperative and a mainstay. The main, I think, decision, other than, you know, dealing with critical injuries, is the role and timing of a C-section. And generally, these are done with maternal, if the mother is non-responsive to resuscitation, if there's an imminent maternal death, or a non-reassuring fetal heart rate on fetal monitoring. So in summary, delay in diagnosis is an overarching theme, in surgical diseases in the pregnant patient, and delay in diagnosis will contribute to worse outcomes, especially with breast cancer, colon cancer, and urgent general surgical or acute care surgery conditions such as appendicitis and cholangiogaphy. High index of suspicion is required by the surgeon when evaluating a pregnant patient, and expeditious and accurate diagnosis will take precedence over ionizing radiation risk to the fetus. Laparoscopy can safely be performed during any trimester of pregnancy, and that goes for laparoscopic appendectomy and cholecystectomy for the treatment of appendicitis and biliary disease, respectively. And with that, I'll take questions if there are any. Thank you.
What about diabetes? We know there's a high incidence of gestational diabetes, especially in our patient population that we see here in San Antonio. Did you come across?
Yeah, so actually, what I came across was the effects of diabetes on being a cause of a high risk pregnancy, and those in turn having fetal loss rates in cholecystectomy. Actually, it was a study from UTESCA, and showed that fetal demise may be in the patient population that they studied. It was Dr. Cornet, Dr. Dent, and Dr. Stewart. In the patient population that they studied, that fetal demise may be secondary to a high risk pregnancy, and diabetes was one of the comorbid conditions that contributed to that. So, I mean, I think it contributes to the risk of the pregnancy, and sure, absolutely, the surgical outcome.
Technically, when you're operating on the pregnant patient too, we need to mention it. Usually the patient has some type of pad.
Right, and is on the left lateral decubitus position.
Right,
Yes, sir.
to get the gravid uterus off of the vena cava. The other thing is, when we were doing them laparoscopically, we started with lower pressures too. And I don't know whether, are you still doing that on the trauma service with APPs? Or you're doing them at 15, but when we started out, we were doing them at 10 because we didn't know from the pulmonary hypertension standpoint and pressure on the uterus.
There are studies that show anywhere from 10 to 15. There's 10 to 12 and then 12 to 15 that show that patients are tolerant of that.
We wrote 2 papers on pregnant patients, one with appendicitis and one with the early studies with laparoscopic cholecystectomy. And if I ever do that again, I'm going to write under somebody else's name because all of the calls came from lawyers. I didn't really think about that ahead of time.
Yeah, details.
But we hadn't seen any fetal loss early on, and that's what we were all concerned about with the start of laparoscopic surgery. I don't know, have you looked at your series recently at all?
Regarding fetal loss?
Yeah.
We
had none initially.
I can't say we had any since I've been here. But we have, I don't know if you can put that specifically, but if anything, it's very, very important.
Dr. Catano, what about hyperthyroidism in the pregnant patient? Are we going to treat them medically, or is it we take them right to the operating room?
Well, I personally haven't had an experience yet since I've been here, but the anti-thyroid medications are contraindicated, especially so I don't think, obviously radioactive iodine is also contraindicated, so I don't think it's going to be surgery.
So we go to the operating room. Any other questions for Dr. Carter? Yes, Dr. Abergili.
The most common cancer in America, in young woman, productive woman, it's not breast, it's melanoma, fortunately it's curable. How about a pregnant woman and she developed a melanoma of her calf and you discover it at the second trimester? How are you going to deal with it? I discussed that with you outside.
Yeah.
A dramatic case. So
That
what does the literature say about this?
I didn't particularly find, I didn't see literature with regards to melanoma specifically, because breast cancer was the second most common and cervical cancer was the first most common in terms of the malignancies associated with pregnancy. But with regards to that case, and what Dr. A is referring to is that pregnant patient was evaluated and found to have melanoma on the calf, and patient, once they delivered, the child was also born with a melanomatous lesion on the torso. So I mean, a wide local excision, just, I would follow the normal non-pregnant algorithm with a lymph node biopsy if we need it.
Yes, Dr. Sestero.
Very nice presentation.
Thank you.
My question is regarding the biliary pancreatitis in the pregnant patient. You mentioned that there's a 60% fetal loss in biliary pancreatitis, which was surprising to me because usually it's a very self-limited process, at least in the non-pregnant patient. patient, or even the pregnant patients we've seen. So I was wondering if that's older data, or if that's complicated biliary pancreatitis.
Yeah, so that was a paper from 2010.